afternoon, or good evening. First of all, on behalf of all the members of GNYP, I would like to give you a warm welcome. We are extremely happy to have you here from all over the world to celebrate our first anniversary, the anniversary of GNYP, Global Network of Youth in Physiotherapy. I'm Michelle Viveen from the Netherlands, and I'm the Vice Chair and Coordinator of Internal Relations of GNYP. I would like to start by giving you a brief introduction about how GNYP is established and how we developed over the last year. That we will have 3 interesting lectures ready for you, and at the end, we will give you more information about the membership of GNYP. Thank you all for being there today to celebrate GNYP's first anniversary with us. Let me take you back to March 2020. GNYP started with our chairperson, Benjamin. He's from Tanzania. His vision was to create a global network for physiotherapy students and young professionals and give them the opportunity to share and develop professional knowledge and competencies within a strong and unique global community. So he contacted multiple student organizations around the world, and we began to work on establishing GNYP. That resulted in the fact that March 2020 we started to develop GNYP. The first 3 quarters of a year was in the light of the creation of official documents, developing the structure of GNYP, and getting to know each other, of course. Once this has been said, we could focus on gaining more members from around the world. Right now, a year after its development, GNYP has around 12 different countries from around the world where people are from to work together, learn from each other, and last but definitely not least, have fun with each other. Education, learning from each other, and sharing knowledge is one of the main foundations of GNYP. That's why today we have our first webinar. This is the first one of more to follow. In the near future, we would like to create a platform where people can share their knowledge, researches, and help each other out. And on the long term, we would like to provide international events and international internships. So for now, this was a brief introduction about what GNYP is and how we were established. And now we're going on to the lectures. At first, I would like to introduce you to Mr. John Marwa Gikaro. He is a physiotherapist from Tanzania and will tell you more about research as an integral part of evidence-based practice. He would like to inspire young people to take one more step towards improving the quality of care. We are very pleased to have you here, Mr. Gikaro, and I would like to give the word to you.
Hello everyone, my name is Johnny Gikaro. I'm a physical therapist from Tanzania, East Africa. I hold a bachelor degree of science in physical therapy, and I'm currently pursuing Masters of Rehabilitation Medicine and Physical Therapy. I'm so glad to participate in the first ever anniversary of the GNYP as a guest speaker. Today, I would like to share with you a lecture with an expectation of inspiring young generation in the GNYP to make one more step towards improving the quality of care. Our talk today goes by the title, Research as an Integral Part of Evidence-Based Practice. In fact, more emphasis will be on evidence-based practice. You are all welcome. I'm affiliated with Nanjing Medical University in the People's Republic of China, School of Rehabilitation Medicine, as a postgraduate student pursuing Masters of Rehabilitation Medicine and Physical Therapy. Also, 2 institutions in Tanzania, namely Kilimanjaro Christian Medical University College and Kilimanjaro College of Health and Allied Sciences, as a physiotherapy tutor at respective departments. Let's go to the aims of this presentation. In most cases, newly graduated therapists who literally have no much experience end up getting guidance from their seniors either during internship or at workplace. On the other hand, some seniors graduated over a decade ago and probably never upgraded their knowledge afterwards. As a matter of fact, some of them still use the very same classic approaches just as business as usual. Indeed, business as usual may be outdated. As such, great therapists should at least be able to evaluate different schools of thoughts in real practice. Lastly, this presentation aims at highlighting scientific way of formulating clinical questions, giving insights of where to find evidence-based databases, and the role of research in clinical practice. This presentation is divided into 4 parts. The first one is introduction, followed by integration of research in evidence-based practice. Also, we have evidence-based databases. And finally, clinical thinking. In the end, we'll have a summary of the 4 parts. The introductory part gives a brief description of basic concepts of research in evidence-based practice and their differences. When talking about research, whether basic type or applied type of research, the focus is adding new knowledge or solving the existing problem. In a very simple way, Western Sydney University describes research as the creation of new knowledge and or the use of existing knowledge in a new and creative way so as to generate new concepts, methodologies, and understandings. Knowledge is science, but the skill is pure art. So in real practice, creativity can create our own brands as physical therapists, which may in turn lead to a number of designs, which in fact are necessary modifications when combined with experience. Now that we know the basic concept of research, how about evidence-based practice? Simply, we can say evidence-based practice is an application or translation of research findings into our daily patient care practices and clinical decision making. So when we have basic scientific evidences from research and we have patient values, preferences, and reports based on what fit them the most, in addition to our clinical expertise, clinical experience, this is what we call evidence-based practice. So simply, we can say applying or translating research findings into our daily patient care practices and making clinical decision is what we call evidence-based practice. If we want to compare these two, research and evidence-based practice, is there a difference? As explained earlier, research aims at generating new knowledge or validating the existing ones based on theory. On the other hand, evidence-based practice, the purpose is to use the best available evidence to make informed patient care decision. Another key difference is that research involves systematic scientific inquiry to answer specific questions or testing hypotheses using disciplined methods, while evidence-based practice uses evidences from research but goes beyond to incorporate clinical expertise, healthcare team, as well as patient preferences and values. In this part, we are going to review the 5 essential steps of evidence-based practice. In addition to that, we will have a quick look at how to assess the quality of evidences we obtain when searching for information. The key steps of evidence-based practice is summarized into 5 A's. The first A is ask. What is your query? Is it answerable? Can you formulate one? This is when we convert information need into an answerable clinical question. The second A is to acquire. Could there be a solution from a reliable source? This is where we need to search for possible answers by seeking the best evidences for answering the question. The third A is appraise. Now that you get the answers, are they reliable? Can they be trusted? Here, we have to test for validity, we assess for validity, impact, and applicability. The fourth A is to apply. Here you make decisions based on experience, knowledge, and clinical judgment. And the last A is to evaluate the steps from number 1 to number 4. Does its application make any difference in terms of outcome as compared to previous regimes? So you do some evaluation, the so-called auditing. Say you are a physical therapist working at a certain hospital, and you notice that a number of patients, especially those aged 60 years and above, who have been attending your clinic, have complaints of radiating pain to the soles of their feet. And based on their condition and age, you have always been prescribing massage therapy and rest. In the long run, you come to do your evaluation and you see no significant changes in terms of pain relief and functions. Now the question comes, what could have possibly gone wrong? What do you do? Can you do something else other than massage therapy and rest? To tackle the above situation, a scientific framework abbreviated as PICO can help you formulate a question and facilitate your literature search. P stands for patient problem or population. I stands for intervention or treatment. C stands for comparison or control. And O stands for outcome or results. So if we go back to our previous example, the problem is radiating pain. The intervention is massage therapy or rest. For comparison, you use a different approach other than rest and massage, and at least it should have been shown to have more effect. For that reason, we can choose exercise therapy, for example, or neurodynamic therapy, for example, and many more. And the outcomes is pain relief or improved functions. So if we use this strategy, this framework, we end up having a comprehensive outcome of published information that gives you evidence supporting your search. After successful retrieval of available information, what next? The next vital stage is to evaluate them. The question is, what do we assess in a particular context? Here we look at trustworthy of those information we got, the values or importance of those information, and the relevancy. Are they applicable to the type of patients we have? Keeping in mind that evidences could be patient-reported, clinician-observed, or research-derived, other factors as well should be considered. These include the quality scores of those articles, the number of times they have been cited, and the impact factor of the journal that has been published. Sometimes you may be interested to get updates of information regarding your area of interest, but where do you get the information you need? This part will help you to identify some key evidence-based databases and open access journals available online. The hierarchy of evidence is top at experimental studies such as randomized controlled trials, meta-analysis, and systematic reviews. In these evidence-based databases, you'll find evidences published in systematic reviews, clinical guidelines, and many more. One of the most common evidence-based database is Cochrane Library. This is the general look of its homepage. It's available through www.cochranelibrary.com. In this database, you may find a range of evidences published in systematic reviews, clinical trials, clinical guidelines, and many others. Another evidence-based database for health and allied sciences is Clinical Key. In here, we can search for conditions, procedures, drugs, and many more. And this is the landing page of Clinical Key. And number 3 is Pedro. This is perhaps the most important one because it focuses on physiotherapy. In here, you'll find practical guidelines in relation to different conditions as far as physiotherapy management is concerned. We also have systematic reviews, clinical trials, and many more. To visit Pedro, please go through pedro.org.au. Other than Cochrane Library, Clinical Key, and Pedro, there are many others out there. For more information, you can browse through the internet and find as much as possible. Despite a high number of journals out there that publish relevant information, still not all of them are readily accessible. Those that are free available online are called open access. You only need an electronic device that can be connected to internet and basic search skills to access them. Examples of these open access journals include BMC, Biomedical Central. It has dozens of journals that can be accessed free of charge. Another one is PubMed. It gives link to available full-text articles. Like BMC, HighWire and PLOS ONE gives you access to browse through their databases for free. For more information, you can visit respective URL beside journal name. Clinical thinking is our last part in this presentation. It explains the need for change from the so-called business as usual. Business as usual, under normal circumstances, extend attendances of the patients. For the sake of our profession, there is only one word: say no to business as usual. It's time for change. And a good change will be accompanied with proper goal setting. So the part of outcome measurement is very crucial in this change. Let's use outcome measurement tools so that we can set our goals based on activities of daily living, functions, quality of life, etc. Here we can measure baselines, plan for treatment approaches, evaluate treatment plans, reassess, review the treatment, treat the patient again, evaluate, and the cycle continue. With this, will make all necessary adjustments into evidence-based practice. In the end, we can ask ourselves, why do we need research in physical therapy? The answer is pretty simple. It's because physical therapy is a scientific approach of patient treatment. So, we need to justify our actions. We also need to standardize the treatments. All this needs research. Secondly, why do we need evidence-based practice? I can also say we need evidence-based practice in order to improve the quality and efficiency of health services, but also to keep updated. In summary, better outcomes depend on careful selection of appropriate plans. As practitioners, we need to generate new knowledge or validate the existing ones in order to get along with the current situation. We have seen that evidence-based practice is a holistic approach. It's beyond research because it involves clinical expertise and patient values. As therapists in 21st century, we need to stay updated. And that marks the end of our presentation. You can have more information online or by consulting seniors. For more information and inquiries, you can contact me directly through provided contact information. Thank you and welcome to Tanzania, the land of Kilimanjaro, the Serengeti, and Zanzibar.
Thank you so much for presenting us a clear view on how to integrate research in our daily evidence-based practice, Mr. Gikaro. I think this is very useful for the students and young professionals in their education and practice. We were very pleased to have you here. And from Mr. Gikaro, we go on to Mrs. Klára Kučerová. She's a physiotherapist from the Czech Republic and will tell us more about vestibular rehabilitation. The aim of her lecture is to briefly introduce vestibular rehabilitation to physiotherapy students and young professionals. We are looking forward to the lecture, and hereby I would like to give the word to Mrs. Kučerová.
Hello everyone. Thank you so much for the invitation. My name is Klára Kučerová and I'm physiotherapist from the Czech Republic who works in Motol University Hospital. Mainly I work with patients with vestibular disorders, so that's why the topic of today's presentation will be vestibular rehabilitation. For me, it's quite hard to make the presentation and to speak just to my computer, not knowing who's really watching it. Maybe you are in first grade, maybe you are just a few months before your graduation. So I try to make the presentation simple for someone who really don't know what vestibular rehabilitation is, but also practical for someone who already had some basic knowledge. So let's start. You as physiotherapy students, you probably have already experienced some patients with imbalance or postural instability. So you saw them walking in the hall and they were not walking straight, they were falling to one side or unspecifically to both sides. Maybe you already saw some patients with vertigo and dizziness. They had problem that their surroundings is moving, or they feel that their surrounding is moving to one side, it's turning, especially when they turn their head or when they're walking. So there are many reasons and many diagnoses why these patients can have these symptoms. The problem can be in vestibular system. Maybe you have never heard about that system and now you're like, oh my God, what is she talking about? But believe me, it isn't anything mystical. It really exists. So what is it and where is it? It's sensory system which register position and movement of your head. So every time when you are turning your head, bending it forward, looking up, or tilt it to one or the other side, these organs are sending signals to your brain that right now something is happening. She is tilting her head or she is turning it, etc. So the first function is registration of your body and head in a space. Also, vestibular system sends signals through neural structures which controls eye movement, and it's responsible for maintaining gaze stability. What does it mean? Basically, it's the stabilization of your eye on one target while are you moving your head. So you can try it. Just look to the sun here on the screen and try to move your head. So turn your head, and if you don't have any problem, then your eyes should stay on the sun. Okay, so it's stabilization of your eye while are you moving your head. Okay, gaze stability, it's another function. Also, the vestibular system is connected through vestibular spinal tract to your postural muscles to keep you upright and in general to control body posture and balance. Okay, also there are pathways, upper pathways to neural structures like cerebellum and cortex. So these are the main function of vestibular system. So keeping head and body straight in space, maintaining gaze stability, and maintaining balance. Okay, this is no time when I usually ask if all was clear. If you have any question, well, you cannot answer right now. Anyway, if you will have any question, you can text me after the presentation. Okay. So this was the physiological situation, and now the pathology. Patients with vestibular disorders have some dysfunction in peripheral or in central pathways. And how do they look like? So, for example, it will be easier if you imagine that someone has got dysfunction in peripheral vestibular system. So here in inner ear, one of the vestibular system is not working properly as it should. So how about the head position and the head movement? So normally when I'm turning my head to my left side, then the vestibular system on the left side is sending a lot of signals to my brain. So I'm turning my head to my left side, and the left vestibular system is saying, oh, she's turning head to my side. And the right vestibular system is saying, she is turning her head. So more signals are coming from the left side to the brain and less signals are coming from the right side. Okay, this is the physiological situation, and the brain thinks, okay, so more signals from the left, so she turned her head to the left side. Also, there are information from the vision and from the neck muscles as well. So this was the physiological situation. What about the pathology? What if my left vestibular system is not working at all and I'm turning my head to the left side? Then from my left side there is nothing, and from my right side there are signals like she turned her head. What about the brain? The brain doesn't receive the information from the left side, just from the right side. So brain can think, okay, she turned her head probably to the right side because I got more information from the right side. But the vision tell me that she turned her head to the left side. Oh, what is it? So the brain is confused and the patient feels dizzy. Okay. What about gaze stability? Because it's connected with head movements. So normally, physiologically, when I'm turning my head to the left side and both systems are working normal, then when I'm turning my head to my left side, my eyes are staying on the target. So basically it means that they are moving to another side than my head, right? So when I look to the sun, turn my head to the left, my eyes are coming to the right and staying on the sun. Okay, that's the physiological situation. What about if I will have damaged vestibular system on my left side and I'm turning my head to the left, my eyes will not stay on the sun and they will move with my head and then they will quickly jump back to the sun. So these patients have problems to keep the eyes on the target. So when they are moving their head, the eyes are not staying or moving to another side, but they are moving with their head. So imagine when you will turn your head and your eyes will turn as well, and then you will feel dizzy. And the last thing is that also these patients will have problems with balance. So as you know, there are systems which contribute on maintaining balance or postural control in standing position. So while you're standing, your brain needs information from your muscles, from your vision, from proprioception, from your hearing, and also from the vestibular system in inner ear to keep you upright and prevent you from falling down. So again, imagine if you will have for some reason dysfunction of the inner ear and so your brain will not receive information from the vestibular system. And for these patients, it's really hard to maintain balance, especially while the other systems are not working properly. So let's use an example again. Imagine that you are a patient with vestibular disorder or vestibular disease. Okay, so it's night and you are sleeping. Just imagine, right? Don't sleep during my presentation, please. So just imagine that you are sleeping, you wake up at night, you want to go to the restroom, but you don't want to turn the light on because you don't want to wake up your boyfriend. So you're walking, it's dark, and for you it's quite hard to maintain the balance and go straight because your vestibular system is not working, your vision is reduced because of dark. So the brain receives information just from your muscles and proprioception to keep you upright. And also, it would be much harder if you will have neuropathy, right? Okay. So hopefully now you can imagine how does the patient feel. It's important to say that we as physiotherapists, we cannot replace or heal the dysfunction of inner ear. But what we can do is that we can help patients to manage or improve these symptoms which I've been talking about. And that's the role of vestibular rehabilitation. So vestibular rehabilitation is specialized exercise-based program to reduce or eliminate the symptoms such as dizziness, vertigo, gaze instability, and imbalance. These exercises help us to, let's say, retrain the brain to better interpret and use the information from the inner ear. Basically, we teach brain and accommodation. I will just go briefly through the principles of vestibular rehabilitation, which we use to promote neuroplasticity. So we can divide them into three categories: adaptation, habituation, and compensation. So adaptation, we use to utilize the remaining function of vestibular system in damaged ear. So we train brain to interpret vestibular signals differently, and we can use it in patients with just decreased function or reduced function of one vestibular system. The habituation is how to reduce neurological responses to an uncomfortable stimulus with greater exposure and repetition of the stimulus. And the compensation, it's basically the training of the other sensory systems to replace the vestibular function. So these are main principles which we use in vestibular rehab. Now I'm going to talk about therapy. What practically you can use. So first important thing I would like to mention is patient's education. What does it mean? Well, imagine that patients with vestibular disorders, which will come to you, will have their symptoms for really long time, for months, sometimes for years. Some of them may had some therapy, some of them are on medication, some of them not. Some of them maybe had some physiotherapy before, but maybe it was more focused on some soft techniques on their neck or mobilization of the neck because someone just told them that their problems are coming from the cervical spine. And some of your patients, maybe they didn't even have been on the therapy because someone just told them that their problems are only in their head. So for you, it would be hard and challenging to explain the physiology and pathophysiology of their problem, to tell them that their problems are in their head, but in the inner ear, and it doesn't mean that they're crazy. Explanation is half part of the therapy, and believe me, if you become really good at it, then patients will trust you and they will get better even before you begin the therapy. So it's important part to explain them what's really happening and also what is the goal of your therapy. So as I've been talking before, usually patients have these symptoms for really a long time. For them, it's quite hard to see any progress. In our clinic, what we do is that we test our patients in the first session, then we find some impairment, we focus on it, and we treat it. So we focus our exercises to their impairment. So patients are coming home, doing exercises at home, then they come again, we check them if they are doing these exercises right, and then we are doing again the examination to see the progress and improvement. For the evaluation of patients' subjective perception of the impairment, we usually use some standardized questionnaires as DHI or Vestibular Rehabilitation Benefit Questionnaire. And the exercise itself, it's focused on the symptoms which I've been talking before. So first of them is gaze stability. Which we can evaluate by dynamic visual acuity test, which you can see on the picture on the left side. So patient is sitting and looking on optotips, and he tried to read the lowest line of the letters what is possible. Then he turned his head, he is turning his head like this, and again try to read the lowest line. And we are looking for the differences between the static and dynamic conditions. We can turn examination into the exercise. So patient can have some picture or the text in front of him, and he try to turn his head and be able to read the text. He can increase the speed because with increased speed it's more difficult for him, and also he can do it in different standing position. So he can sit, he can stand on one leg, he can stand in tandem, or he can stand on the foam. So this is the exercise for gaze stability. Other exercises are focused on balance while standing. For examination, we can use, for example, CTSIB, which is test of standing with in different sensory conditions. So we test patients while he's standing with his eyes open, with his eyes closed, and also on different surfaces. Again, we can turn the examination into the exercise. So we start training the easiest condition with patient while he's standing on the front surface. Then we can change it. He can stand on on the foam surface. He can close his eyes, or we can add that he can turn his head to the sides or up and down, and maybe he can also say the alphabet from the end. So we try to make it most challenging for the other sensory systems to maintain the balance. And the first part is focus on balance, but during dynamic conditions. So while patient is walking. For the examination, we can use tests as time up and go, or dynamic gait index, or some other test from your country which you know and I didn't. Yeah. We use in therapy, we focus on walking with head movements. So we can use horizontal head turns or the vertical one. So we instruct patient to walk straight in the hall and try to turn his head without falling down, without stepping aside, or without stopping. So again, we can start in the easiest condition just with one turn. So he can walk 10 meters, and on this 10 meters, just once turn his head to left and right side and just continue walking without reduce of the speed or stopping. And then what we can increase is speed of the turns, or also more and more movement, so number of the turns. Okay, so these were just the examples which you can use in your therapy, but it's all up to your imagination and your creativity. So everything is possible, and you just need to test patients right, find their impairment, and then focus on them the therapy. Okay. So, well, that's all from me for today. I would like to take with you some messages from today's lesson. First one, that vestibular rehabilitation is very important. It's really good treatment for vestibular dysfunctions. It helps us to reduce symptoms such as dizziness, vertigo, gaze instability, and imbalance through the neurological compensation. And the last one, the most important, it's easy. Okay, so again, thank you so much for the invitation. I appreciate it. And I hope you're not dizzy after all. And I wish you to find your own balance. Thank you so much, and have a nice rest of the day.
Thank you very much for your interesting presentation, Ms. Kučerová. You gave the audience something to hold on to in clinical practice for vestibular rehabilitation. We were very pleased to have you here with us today. From Ms. Kučerová, we go on to our last but definitely not least keynote speaker of today, Dr. Mina Ashraf Sadek from Egypt. He is passionate about technology and designing models himself. Today, Dr. Sadek will tell us more about exoskeleton technology and its role in neurorehabilitation. A warm welcome to Dr. Sadek.
Hello everyone, my name is Mina Ashraf, a physical therapist from Egypt. carrying a bachelor degree of physical therapy from Paris University in Alexandria, 2015, master student in neuroscience from the Euro-Mediterranean Master in Neuroscience and Biotechnology in coordination with Bordeaux University in France, and an academic researcher in Armed Forces College of Medicine in Egypt. Today we will introduce an overview about the exoskeleton technology and its applications in neurorehab field, and especially in rehab of spinal cord injury patients. At first, we will talk about the exoskeleton as a technology. It's just a wearable device, can be worn by the user. Its main application is to augment or replace lost function of the patient. The origin of exoskeleton concept was Russian. It was firstly invented by Nicholas Eugen in 1890. And in 1970s, the American inventor Leslie Keeley was invented an exoskeleton. Its aim is to increase the velocity of the runners. In 1965, General Electric Company has invented its own exoskeleton. Its aim is to augment the power of her engineers and workers. But this exoskeleton has faced many problems, starting from its very heavy weight, which was exceeding 1500 IPS, in addition to many technical problems has faced the company at this time. In 1971 was the first trial to enter the exoskeleton in the medical field by University of Washington, which invented her first exoskeleton used in medical field. This exoskeleton was very complex in its structure and its function. It consists of 4 pneumatic dampers in the 4 joints, hip and knee, and it has a very complex computer system. Nowadays, exoskeleton has entered in many applications. From the military application like Iron Man, I think all of you has watched this movie, and the medical application, and this is our topic today, and in the industrial application. So, in the medical field, the skeleton is considered as an orthotic device with motors are suspended on the main joints, which is hip joint and knee joint, and its main aim is to restore the ambulatory function, the lost ambulatory function by the spinal cord injury patient and other neuromuscular disorders. And in order to manage to achieve these functions, the exoskeleton is considered as an inspired system from the human neuromotor system. So it consists of a control system, which resembles the human neuromotor system, the power system, which is the battery in the exoskeleton, and finally the kinematic system, which is the programming and software of the exoskeleton. The exoskeleton technology is facing many problems and disadvantages, starting from its robotic gait, which make it not smooth enough, and its low battery life, and its cost, which prevent it from spreading in the whole world. The main lesion which we are focusing on is spinal cord injury, which is a damage in spinal cord that causes temporary or permanent changes in function. It has many causes, starting from traumatic injury like war veterans from gunshot, car accidents, and many non-traumatic injuries like spine tumors or advanced disc collapses. The main goal of exoskeleton in these cases is to restore the lost motor function or to relearn the patient how to move or how to walk again. In 2019, there is a paper published in Nature Medicine talking about a neural circuit in the lumbosacral segment. This neural circuit works as a peripheral brain for the motor or the ambulatory function. This neural circuit is stimulated by an accurate feedback from the lower limb during motor training or ambulatory training. The more accurate the feedback coming from the motor training, the more initiated this neural circuit, which can create more neuronal connections and can start to control the lower limb and regain the motor function. As we see in these videos, the manual ambulatory training and the training using the treadmill and the exoskeleton rehab training. You can show that this is the exoskeleton rehab training is more accurate and the more function than the other rehab training. And in Egypt, we have started our journey in the exoskeleton field by designing the exoskeleton itself. We have started by a primitive prototype from scratch to the exoskeleton in 2018, and then resumed the development process until reached to this prototype, which is much more advanced from the primitive one. This is Cosmos 1. This prototype is composed of 4 motors on the main joints, 2 on the hip joints and 2 on the knee joints, allowing ambulatory function on the sagittal view with a full back support, which allows us to work in the clinical trials on higher injuries. It consists of a controlled setup. Its control interface is a joystick set up on the crutch itself and embedded on it a heartbeat sensor to measure the heart rate measurements of the patient in a real time to prevent any tachycardia during the gait rehab. And this is me wearing my first prototype. After finishing the mechanical device and the design of electronics, software, and kinematic algorithms, we have created a graphical user interface, which is used to measure in real time the performance of the device itself and the user during the gait rehab session. After many trials and errors, we have reached to this. This is a comparison of the kinematic model between our Cosmos 1 exoskeleton in comparison with ExoGT in the USA and Reebok in Israel. And this is a comparison between the 4 commercially used exoskeleton in the world, which is Reebok, Exo, Indigo, and Rex, and our sample. It's clear that the weight of our exoskeleton is 11.6, which means it's the lightest exoskeleton in the whole world. Our exoskeleton is used for rehab purposes only. The control interface of our exoskeleton is joystick, and it's typical with Rex exoskeleton. The average height of patient which can use our exoskeleton is averaged between 155 centimeter to 191. Before starting our clinical trials, we have received the acceptance from our institutional review board to start to use our technology in clinical trials and on real patients. Our first exoskeleton pilot in Egypt is Mrs. Jihan Abdallah Regis. Her age is 58 years old, weight is 78 kilograms. The date of injury is the 1st of September 2017. She is diagnosed by complete injury in the thoracic level T10 with complete loss of motor function and control of bowel and urinary functions. As I distinguished before, the main aim of exoskeleton is allow the patient to stand up, walk, and sit down again with the maximum safety available. At the first, we are teaching the patient how to stand up again by teaching him how to weight bear on his feet and his crutches, and how to weight shift during sitting and during the standing process itself. This is the first standing to Mrs. Jihan Abdullah after 1026 days from her injury. And after more and more repetitions, it became smoother. And this is what exoskeleton do in motor learning of the patient. Even in remote exoskeleton, this process also is difficult at the beginning. Until finally she managed to stand up with her own using her two crutches. This process is difficult, but she did it. We repeat this sequence in training the gait pattern also. Her first step using Cosmos exoskeleton was one step and she has stopped. And after more and more repetitions, she managed to walk with two crutches with the aid of our graphical user interface software, which allowed her to teach and learn every single step. And it's a comparison between the motor learning process between Cosmos exoskeleton and remote exoskeleton. It's very difficult on the patient to relearn the motor pattern again. Until she managed to walk more smoother after 1 month of her exoskeleton sessions. Her transition become smoother. And by that, we can say that we have managed to design our first Egyptian exoskeleton for spinal cord injury patients and neuromotor disorders. Thank you for watching, and for any questions, feel free to contact me anytime. Thank you.
Thank you so much, Dr. Sadek, for giving us an interesting insight of the use of exoskeletons in neurorehabilitation. And congratulations on your design of the Egyptian exoskeleton. We are very thankful for your presence. And we are extremely happy with the 3 keynote speakers of today. And of course, we would have wanted to have this physically to meet you all, but we're pleased to celebrate our first anniversary with you this way. The lecturers will all receive a certificate for participating in the GNYP webinar. We hope you enjoyed this webinar, and that brings us to the next topic of today, the membership. As GNYP has grown slowly, we want to be able to create more content for our members. This content cannot be created without your help. This is why we start the membership. As a member of GNYP, you are part of a worldwide network of students and starters in physiotherapy. Beside the fact that you can get in touch with other students from all over the world through this network also has other advantages. This gives you exclusive access to online lectures and social events. As GNYP, we are also working hard to be able to do more physically and online for you in the future. Not only in contact with each other, but also to offer internships and contact with universities and colleges to bring together physiotherapy students from all over the world. This is so that we can share experience, learn from each other, and this with the aim of better connecting physiotherapists from all over the world, and thus improving care for our patients. The membership system is designed to give everyone a fair chance to be part of GNYP. All countries all over the world are divided into groups. This split is carried out on the basis of the World Bank formats. The basis of the amount of annual quota is based on the GNI per capita. The GNI per capita is the dollar value of country finals income in a year divided by its populations. It should represent the average pre-tax income of citizens of a country. The different groups with corresponding prices can be seen on the website. Being a member is free until the 1st of September. If you choose to become a GNYP member in a week of this webinar being posted, you will receive a 10% discount on your first year as a member. Please join us on our journey.